We continue our discussion on stroke, and now I'll be talking to you regarding posterior circulation stroke. But before I talk about this, let us revise our neuroanatomy, especially regarding circulation in the brain, without which you will never understand this topic. So we have, at the moment I'll talk to you only regarding posterior circulation. So we have these two vertebral arteries, these two vertebral arteries, and they unite to make the basilar artery. Okay. Now this is anterior spinal artery, which arise from the two vertebral artery. They unite to make single anterior spinal artery, and this is the pica. Pica stand for posterior inferior cerebellar artery. Okay, and this artery, this is the ICA. ICA stand for anterior inferior cerebellar artery. So pica is posterior inferior and ICA is anterior inferior cerebellar artery. Well, these are the pontine branches. These are the pontine branches, and here is the superior cerebellar artery. And this is the posterior cerebral artery, PCA, and this is the posterior communicating artery, posterior communicating artery. By this, posterior circulation is connected to the anterior circulation, that is via internal carotid artery. Okay. In fact, posterior communicating artery is a branch of internal carotid artery which unites internal carotid artery to the posterior cerebral artery. So this is the anatomy. These are the arteries which are going to supply the brain stem. This artery we will be talking about. Now, when we talk about stroke in brain stem, first thing is medulla oblongata. So let's have quick recall. What are the arteries which are supplying the medulla? Is vertebral artery, anterior and posterior spinal arteries, posterior inferior cerebral artery, and basilar artery. So now let's talk about what happened in lateral medullary syndrome. Again, we should know the basic concept about anatomy. Of the medulla. The basic concept goes like this. This is the inferior cerebellar peduncle. By this, cerebellum is attached to medulla oblongata, and here is the 10th nerve nucleus. This is the 8th nerve nucleus, 5th nerve nucleus, descending fiber of sympathetic chain, and here is the spinal lemniscus. Okay. What does this fiber carry? They carry, spinal lemniscus contain contralateral pain, touch, temperature. Or I can give a better simple example. In fact, we all know that these contralateral pain, touch and temperature are carried by spinothalamic tract. Of the contralateral side. In fact, same fiber, when they enter the brain, the name changes to spinal lemniscus. That's why if you read some of the books, they write this to be spinothalamic tract. But some of the books they write about spinal lemniscus. Okay, my idea to telling you is the problem is in the name, but as far as our content is concerned, same. Both spinal lemniscus and spinothalamic tract, they contain contralateral pain, touch and temperature. Remember, this spinothalamic tract is on the right side. This is the right side, this is left side. So this right sided, they contain contralateral pain, touch and temperature. This is basic anatomy. Now this part of the brain is supplied by vertebral artery. But again, there is some confusion is there. Some of the books they write vertebral artery, but some of the books they write this is supplied by pica. I hope you remember pica is posterior inferior cerebral artery. But pica itself is a branch of vertebral artery. So again, I don't want that any confusion should be there. So you should be are now aware this can be supplied by both, right? So now after this arterial supply, now let us see how patient will manifest. You have understood the basic concept. So there will be ipsilateral cerebellar features, ipsilateral 10th nerve palsy, ipsilateral 8th nerve palsy, ipsilateral 5th nerve palsy, and due to ipsilateral 5th nerve palsy, there will be loss of pain and all sensation in the ipsilateral side. Remember, all due to 5th nerve, motor and sensory fiber will be involved in the ipsilateral side of the face. Ipsilateral Horner syndrome, but contralateral loss of pain, touch and temperature. Remember, sparing the face. Contralateral in the entire limbs, pain, touch, temperature will be lost, but pain, touch, temperature will be lost on ipsilateral side, right? So now if I have to draw a picture of what I have told you, the picture will be like this. Sorry, I am not a very good artist. Well, this is the right side and this is the left side. And remember, in this case we are talking about right lateral medullary syndrome. What I discussed was all lateral medullary syndrome, is also known as Wallenbach syndrome. Okay. Now how patient will manifest? There will be ipsilateral loss of all sensation, pain, touch, temperature in particular, and there will be contralateral in the body. This is what we get in lateral medullary syndrome. Okay, so in lateral medullary syndrome, so-called Wallenbach syndrome, there will be ipsilateral cerebellar features. That means the patient will have ipsilateral all cerebellar feature including nystagmus, including gait abnormalities, ipsilateral 10th nerve palsy, 8th nerve palsy, 5th nerve palsy. I told you how the patient will manifest, ipsilateral Horner syndrome, and there will be contralateral loss of pain, touch, temperature. But remember, there will be phase, contralateral phase will be normal. Here ipsilateral phase will be involved. Right? I hope you understood the things very clearly. Now I have a question. You can listen to the question, stop the video after listening to the question, write down the answer. Now tell me, in which condition there is loss of sensation in the entire contralateral side, including face, including the face. Okay, what I mean to say, this is the person, and here is the loss of sensation, complete loss of sensation contralateral. In which condition this thing happen? Okay, write down the answer. I hope you have written the answer. The answer is thalamic bleed. If right bleeding occurs in the right thalamus, and there will be entire contralateral loss of sensation will be there all. Remember, there will be loss of pain, touch, temperature, position, vibration, every sensation will go in the contralateral side. And one more thing, during the recovery phase of thalamic bleed, patient develop intense burning sensation in the contralateral body. Write down the answer. What is that syndrome known as? Where recovery phase patient has pain and burning in the contralateral body. I hope you have written the answer. The answer is Dejerine Roussy syndrome. This I have discussed in great detail, where I discuss regarding thalamic bleed in another lecture. I hope you have seen. If not, see that lecture also. So I hope you are much wiser about lateral medullary syndrome, so-called Wallenberg syndrome. Now I'd like to talk more about medulla, and now I'm talking to you regarding medial medullary syndrome. But before that, again we go back to the basic concept of anatomy. This is the corticospinal tract, also known as pyramidal tract. They are going to supply the contralateral motor fibers to the other side of body. Here is the 12th nerve, and here is the medial lemniscus. Couple of minutes back we talked about spinal lemniscus, which contain the pain, touch, temperature from the contralateral body, which in fact they are the continuation of the spinothalamic tract. This medial lemniscus is the continuation of the posterior column, contralateral posterior column. That means they will contain position, vibration sense from the contralateral body. So if it is the right-sided medial lemniscus, it contains left-sided position, vibration sense. With this background, now this part of the brain is supplied by a direct branch from vertebral artery, and this lesion is known as medial medullary syndrome. How the patient will manifest: ipsilateral 12th nerve palsy, contralateral loss of position, vibration, and contralateral hemiplegia. So in medial medullary syndrome, ipsilateral 12th nerve palsy, contralateral hemiplegia or hemiparesis, whatever you can say, and contralateral loss of position vibration sense. From medulla we move up, and now we have pons. So again, before I discuss the lesion in pons, that is Miller-Gubler syndrome, let me tell you some basic concept about anatomy of pons. This is the pons. Here is the corticospinal tract, which contain motor fibers, pyramidal tract, and here is the sixth nerve, and here is the seventh nerve. Seventh nerve revolve around the sixth nerve nucleus. Now this part of the brain is supplied by branch of ICA, anterior inferior cerebellar artery. If this branch is involved, how patient will manifest? Ipsilateral sixth and seventh nerve palsy, and there will be contralateral hemiplegia, and this is known as Miller-Gubler syndrome. So in Miller-Gubler syndrome, artery involved is ICA. There will be ipsilateral sixth and seventh nerve palsy, and there will be contralateral hemiplegia or hemiparesis. Now I like to talk about something more depth of pons lesion, that is Fowell syndrome. This is inferior medial pontine syndrome is the other name, but before that you got to know some more basic concept. Till now I talked to you regarding sixth nerve and seventh nerve. Okay, now I will be talking to you regarding medial longitudinal fasciculus, and I like to talk to you regarding PPRF. What are these two structures? This you should know. First of all, I like to talk about MLF. MLF is the medial longitudinal fasciculus. MLF, medial longitudinal fascicle. What is its function? Let's learn a very basic concept. We know there are eyeballs. Remember, eyeballs, they move exactly parallel. Look at my eyes. Now I am looking at this side. This is lateral rectus and medial rectus, supplied by sixth nerve, supplied by third nerve. Now I am looking this side. Lateral rectus, sixth nerve, medial rectus, third nerve. So of course there are different muscle, and there are three major nerves, that is third, fourth and sixth nerve, and they are coordinating. And remember, the eye movement are exactly computerized movement parallel. There is no deviation in a normal eye. But again, different muscles, different nerves are involved. How they can work in such a coordinated way? This is done by the medial longitudinal fascicle. What is the function? This is the third nerve nucleus. This is the fourth nerve nucleus. This is sixth nerve nucleus. They are united each other via MLF. And due to this structure, they have exactly computerized movement is there. So I hope you are clear about MLF. Now let us talk about what is this PPRF. Remember, these two are PPRF is just lateral to MLF. Now what is this PPRF? This is a short name of the paramedian pontine reticular formation. It is involved in the eye movement, particularly in the lateral gaze. Okay, mainly it concerned with the lateral gaze. That means, remember, now I am looking this way, horizontal movement. Of course, sixth and third nerve are involved, but it is PPRF is the one which is coordinating this eye movement, right? So if this structure is also involved, then what is known as Fowell syndrome? The structure involved are corticospinal tract, seventh nerve and sixth nerve. That means whatever we had in Miller-Goodwin syndrome, it is there. But what is extra here? Involvement of PPRF. Remember, when only sixth nerve was involved, that means there was a gaze palsy on one side. Suppose right sixth nerve involved, the patient cannot see on the right side because of right sixth nerve palsy. But if PPRF is also involved, then there will be impairment of entire lateral gaze. So in nutshell, we can say Fowell syndrome is nothing but a combination of Miller-Goodwin syndrome plus lateral gaze palsy. This is Fowell syndrome. Now we talk about basilar artery locked-in syndrome. Again we go back. Look at this. Well, suppose patient has right-sided Fowell syndrome. So what happened? Right-sided. So there will be left-sided hemiplegia, yes, and there is lateral gaze palsy. Agreed. Suppose he has bilateral Fowell syndrome, so he will be also having right hemiplegia. In nutshell, there will be quadriplegia. He has all the four limbs totally paralyzed. There is no lateral gaze. Because of quadriplegia, he cannot move at all. Because of lateral gaze palsy, he cannot look right and left. But vertical upward, up, down movement will be normal. And patient will be fully conscious. He is conscious and totally paralyzed, and only movement possible is vertical gaze. This is known as locked-in syndrome. Locked-in syndrome are particularly involved when basilar arteries are involved. Basilar artery branches of pons are involved, and that leads to locked-in syndrome. Why? Because LIS they call as locked-in syndrome. He can think, he can feel normally, but he cannot move at all. And so patient is locked in his own body, he cannot move at all. And this infarct or hemorrhage in the pons. So in locked-in syndrome, the main site of problem is in the ventral pontine. Infarct or hemorrhage, and in this case, patient has quadriplegia, lateral gaze palsy, normal cognition. Now I will talk to you regarding midbrain lesions. Now midbrain is supplied by posterior cerebral artery, superior cerebral artery, and basilar artery also. Okay, this is basilar artery, superior cerebral artery, and posterior cerebral artery. So before I discuss lesions, let me discuss the basic anatomy. Well, in midbrain, this is the corticospinal tract. This is the third nerve. This is the right side, and this is the left side. And here is the red nucleus. okay, and here is the superior cerebellar peduncle. Superior cerebellar peduncle, by this structure cerebellum is attached to midbrain. Now this is the cerebellum of left side. Well, now this right-sided red nucleus, it get afferent from cerebellum of left side, and it give rise efferent to cerebellum of left side. Okay. Well, this is the basic anatomy. So now this part of the brain is supplied by branch of posterior cerebral artery. This is the right-sided lesion. How patient will manifest? Patient will manifest with right-sided third nerve palsy, right third nerve palsy, or you can say right or ipsilateral third nerve palsy. I am writing ipsilateral, and there will be contralateral hemiplegia. So this condition is known as Weber syndrome. So in Weber syndrome, ipsilateral third nerve palsy, contralateral hemiplegia. Just clear. Now this part of the brain is supplied by another branch of PCA. Now structure involved are third nerve nucleus and red nucleus. How the patient will manifest now? There will be ipsilateral third nerve palsy, no doubt about it, but there will be contralateral cerebellar feature. Why? Because this red nucleus is getting efferent from cerebellum of other side and giving efferent to cerebellum of other side. So this is known as Benedict syndrome. Right? At time, the involvement may be third nerve nucleus and superior cerebral peduncle, like this. That means red nucleus is not involved. So, but clinically, patient will have same finding: ipsilateral third nerve palsy and contralateral cerebellar feature. So clinically, there will not be any difference, but only difference between the two is that in Benedict syndrome there was involvement of red nucleus. Now this is known as North nasal syndrome. In North nasal syndrome, it is involvement of superior cerebral peduncle, artery involved same, clinically is same. At time, these all are involved, and this is known as Claude syndrome. Artery involved same, clinically also same. Only the difference is in anatomy. In anatomy, in Claude syndrome, red nucleus, third nerve nucleus, and superior cerebral peduncle all are involved. Or in nutshell, we can say Benedict syndrome and North nasal syndrome together are known as Claude syndrome. So I hope you have understood it. With this background, so in midbrain lesion you get Weber syndrome, ipsilateral third nerve palsy, contralateral hemiplegia. In Benedict syndrome, ipsilateral third nerve palsy, contralateral cerebellar features. We have North nasal syndrome, ipsi third, contracerebellar, and Claude syndrome. Claude is nothing but a combination of Benedict and North nasal is Claude syndrome, ipsi third, contracerebellar. So if I have to give you a summary, this is summary of the midbrain. Now I'll give you summary of the summary of midbrain. The summary of midbrain goes like this. In all the four syndrome, there is ipsilateral third nerve palsy. In Weber, there is contralateral hemiplegia. In rest all three syndrome, there is contralateral cerebellar features will be there. Now, one more thing, like I like to note it, that we got syndrome like Weber syndrome, we got Miller-Guilbert syndrome and medial Mallory syndrome. In all these three syndrome, we are getting ipsilateral cranial nerve palsy and we are getting contralateral hemiplegia. Okay. So this point should be very, very clear to you that there are few conditions where we have contralateral hemiplegia with ipsilateral cranial nerve palsy. Now let's talk a little bit more about midbrain. Again, little bit more anatomy. This is the dorsal part of the midbrain. We have a superior colliculus, and this is cerebral aqueduct is there. This is superior colliculus. And why it is so important? Well, when we talk about locked-in syndrome, I told you vertical gaze is normal. Remember, in locked-in syndrome, the lesion was in pons. But why vertical gaze was not? Because vertical gaze center is interstitial nucleus of Casal, and this lie in midbrain. That's why in locked-in syndrome, vertical movement was not involved. So now, obviously, if this part of the brain is involved, that means so-called dorsal midbrain syndrome. So what will happen? There will be paralysis of upward gaze. Remember, in this case, horizontal gaze will be normal because that center lies in the pons. And some retraction of eyelids can be there. This one is Collier's sign. But this is the most important thing that you got to remember. In Perronat syndrome, upward gaze palsy is not there. Well, a quick recap of what we learned in this particular lecture. We talked about lateral maltodextrin syndrome, so-called Wellenberg syndrome. In this, ipsilateral cerebellar 10th, 8th, 5th, Horner and contralateral loss of pain, touch and temperature. Please note here there is no hemiplegia. In medial Maltodextrin syndrome, there is ipsilateral 12th nerve palsy, contralateral loss of position vibration and contralateral hemiplegia is there. Miller-Guilbert ipsilateral 6th, 7th and contralateral hemiplegia. In Fowell syndrome, Miller-Guilbert syndrome and lateral gaze palsy will be there. Gaze palsy will be there. In locked-in syndrome, upward movement will be hampered, but horizontal movement are totally gone with quadriparesis. In Weber syndrome, in third nerve palsy with contralateral hemiplegia. In Benedict syndrome, third nerve palsy with contralateral loss, contralateral cerebellar feature. In Perronat syndrome, paralysis of upward gaze will be there. Thank you very much for watching this video.